Good morning, ladies and gentlemen. My name is Jennifer Laidley Kelly, and I'm here to present my DMP project to you. The title of my project is Transition of Care from the Acute Care to Long-Term Care, Preventing 30-Day Readmission. I would first like to thank my committee members, Dr. Rita Wunderlich, for all her invaluable advice and directions on completing this project. I would also like to thank Nicole Stack-Wade, Janaea Jameson, Melissa Pollock, Robert Brown, and Dr. Taft Coley for their invaluable work that they did along with me to complete this project. The research question was, patient in long-term care facilities, does the implementation of real-time analytics compared to no use of real-time analytics decrease 30-day readmissions and acute care visit post-hospitalization? The purpose of this quality improvement project was aimed to facilitate an open line of communication between the providers from the acute care facility and the long-term care, utilizing real-time analytics to identify patients who are at high risk for readmission to the hospital and/or acute care emergency room visit, post-acute care stay, and transition to the long-term care facility. This education intervention's validity was evaluated to determine if the educational intervention provided improved communication between the providers in preventing 30-day readmissions and ER visits. It was found that residents who transitioned from a higher to a lower level of care had an increased readmission rate and complications. To address this issue, the facility adopted the use of real-time analytics to provide an electronic communication avenue between the healthcare teams. Significance. Inconsistent communication is not a unique issue in the healthcare that's just marginalized. However, it continues to be one of the most problematic clinical areas, and even with the use of the electronic medical record, providers continue to encounter the bureaucratic roadblocks that prevents effective communication. Significance. Communication is critical to patient care, transition of care, healthcare status, and the continuation of care once the patients leave the acute care setting. Timely, consistent communication between providers is needed to deliver and ensure the right care is provided without delay or serious adverse effects. Success in health management of patients take more than just one discipline or entity within the healthcare sphere. It will take consistent communication between all care providers to change this modifiable risk. Background. Inconsistent communication in healthcare. According to O'Daniel and Rosenstein, communication and collaboration is vital to patient safety as well as in the prevention of errors due to communication failure. King et al., in their research finding, identified several barriers to communication when nursing personnel relied solely on the information on the transfer summary. Readmissions back to the hospital is a sentinel event and must be mitigated at all costs. Avoidable readmission that is due to an error or delay in the medication or treatment due to human error. These occurrences are due to human factors such as failure to communicate and are termed near miss, the Joint Commission. Lack of communication have led to adverse patient events, minimized quality of care, and have increased readmissions to the hospital post-transition. Methods. A qualitative exploratory design through a retrospective chart review using a pre-post design that required no resident engagement. By employing this qualitative research methodology in this research study, it will help to strengthen the rigor as well as decrease the potential for biases when compared to other research methodologies. Sources used for data abstraction. The electronic medical record, the admission reports, and the discharge was used as a part of the data abstraction for this project. These are my data collection tool that was utilized during this project. The results. Descriptive statistics was used for data description. The racial ethnic background of the population identified for the project consisted of 60% Caucasian and equal 45, 30% African Americans and equal 22.5, and 10% Hispanic and equal 7.5. Figure 2 shows the gender breakdown of the project. 59% were female and 41% were male in the pre-collections. Post-collection showed a 69% female and 31% male in the post-collection. Results. The data collected to evaluate the pre-post 30-day readmission and acute care visit was analyzed using a lower tail C-test of two proportions with a significance of 0.05 and a confidence of 95%, utilizing a longitudinal design. Analysis of the data for 30-day hospital readmission. The lower Z-tail test for the difference of two proportion showed a hypothesis difference of 0, a level of significance of 0.05. Post-intervention, number of items of interest were 16, the sample size was 75. The pre-intervention, number of items of interest were 22, and the sample size was 75. Intermediate calculation revealed group 1 proportion of 0.2133, group 2 0.2933. Difference in the two proportion was negative 0.08. Average proportion was 0.2533, and the Z-test statistics was negative 1.1264. The lower tail test showed a lower critical value of negative 1.6449, p-value of 0.1300, which indicated that we should not reject the null hypothesis. Confidence interval estimate of the difference between the two proportions. Confidence level was 95%. Intermediate calculation for the Z-value was negative 1.9600. Standard error of difference between the two proportions were 0.0707, and the interval half width was 0.1386. Confidence interval in the interval lower level limits was negative 0.2186, and the interval upper limit was 0.0586. The Z-test difference between the two independent proportion, the analysis post ad hoc computed achieved power. The input was one tail, Proportion P2 was 0.2133. Proportion P1 was 0.2933. The standard error probability was 0.05. Sample size group 1 was 75 and the sample size group 2 was 75. The critical Z was negative 1.64485 with a power of 0.31305. The p-value of 0.1300 is greater than the significant level of 0.05. Therefore, this is not sufficient information to suggest a decrease in the ratio from the pre to the post intervention. The confidence interval suggested the true change in ratio from the pre to the post intervention. Since 0 is included with the interval, we do not have a significant evidence to show a change in one direction. Therefore, the power of the study is 0.3013, which is considered a low to medium in strength. Analysis of the data for the acute care and ER visits. The lower tail z-test for the difference of two proportion was utilized as well. The hypothesis difference was 0. The level of significance was 0.05. Post-intervention, number of items of interest were 8. Sample size was 75. Pre-intervention, the number of items of interest was 30, and the sample size was 75. Intermediate calculation revealed Group 1 proportion of 0.1066, Group 2 proportion of 0.4. Difference in the two proportion was negative 0.2933, average proportion was 0.2533, and the z-test statistic was negative 4.1302. The lower tail test revealed a critical value of negative 1.6449. Confidence level in estimate of the difference between the two proportion. The confidence level was 95%. The intermediate calculation revealed a z-value of negative 1.9600. The standard error of the difference between the two proportion was 0.0669. The interval half-width was 0.1310. The confidence interval revealed an interval lower limit of negative 0.4244 and an interval upper limit of negative 0.1623. The z-test proportion, the difference between the two independent proportions. The post-analysis Hawk computed achieved power showed an input tail of 1. Proportion P2 was 0.1066. Proportion P1 was 0.4. Alpha error of 0.05. The sample size group 1 was 75 and the sample size group 2 was 75. The critical Z was negative 1.64485. The power showed 0.99584. Therefore, the p-value was less than 0.001, which indicated that it was less than the significant level of 0.05. There is sufficient information to suggest a decrease in the ratio from the pre to the post intervention. The confidence interval suggests a true change in ratio from pre to post intervention. Since 0 is not included with the interval, we have a significant evidence to show a change in one direction. The achieved power of the study is 0.9959, which is considered a high strength. Results. The z-test output between the two independent proportions scored showed a critical z of negative 1.6449, a p-value of 0.1300, which is greater than 0.005, which further showed there is not sufficient information to support there was a decrease in the pre-post intervention, which supported not to reject the null hypothesis. The pre-implementation group for the acute care ER visits and the post-implementation group showed a critical Z of a critical Z of negative 1.6449 with a p-value of 0.001, which is less than the significance of 0.005. This showed a significant evidence where a change in one direction was noted, which would support rejecting the null hypothesis. The project further looked at the overall readmission and acute care visit. The project results were consistent with other studies finding regarding the high risk of hospital readmissions and acute care ER visit post-discharge from a high level of care to a lower level of care. The first 30 days post-discharge yield a higher risk due to their diagnosis and the comorbidities that increase their vulnerabilities. The use of predictive analysis is very limited and has now become a growing trend in the healthcare field, and its use is still not at the forefront of technological advancements. Negative implications for this study that were identified: limited health information access, no universal access to clinical data, and lack of interoperability. Positive implications that were noted: better communication between the clinicians and the providers, increased efficiencies in caring, and insight on high-risk patients. Therefore, having a structured and comprehensive EMR platform, such as real-time, offers many safeguards for providers, such as improvement in having immediate access to the patient's medical information. Accordingly, many aspects of healthcare and the use of the electronic record system have changed, and many new systems have been added with very innovative features which have helped the healthcare industry. That completes my presentation. I hope you enjoyed it. Are there any questions? These are my references that were utilized during this project.